Good afternoon, sir. Welcome to Medanta Cardiac Conclave. Uh, we would like to know what is your experience till now and how are you feeling about this conclave?
Good afternoon, Dr. Shreyas. It is a very nice experience to be here. First of all, the organization is very good. Right from sending messages to mails to organizing the program, it is not an easy task to do. And I would like to congratulate all of them who have put the effort to make it become successful. It is, we just had at least half day of the conference, and I can see the conference is of very good level. The venue is also very good, and we have a lot of speakers who are at international level speaker and national level speakers. The cases discussed are very good, and we get the chance to ask whatever questions we want, and both with the national and international faculty. And I think it is a very good conference. We should continue doing it every year and present your cases, your college's cases, and then other cases from other faculty members, so that this is a way we learn how to do things properly and not to repeat the same mistake that has been done previously. And this is a way we can improve our cardiology practice, especially interventional cardiology practice, and give our best to our patients who need us the most.
We also like to thank you, sir, for attending this conference, making time for it, and discussing in the larger perspective. How do you see the future of cardiology in a state like Bihar? Because you have been in Bihar, you have studied in Bihar, so we would like to know what extra things we can do to develop cardiology in Bihar.
Yes, as you said, I studied from Darbhanga Medical College. I was from the 91 batch, and I haven't been to Darbhanga since I left in 2000. In 1999, I left. And I don't know how the state of affairs are there, but I hear that the college has changed a lot. But I used to come to Patna. But when I see Patna now, how it has developed,
Yeah.
the roads. This morning I went for a morning walk just near the chalk here, and I was in Gandhi Maidan, and I've never seen so many people exercising at the same time. There were thousands of people, because I think they told me that there is some police, Bihar police entrance exam or whatever in India.
Yeah.
But so many people exercising, and that is a very good sign that the government of India or the government of Bihar has put into practice. They have instilled in the minds of the population that exercise is a very good thing, and that is very good. And I took that opportunity to do one round myself. Yeah, just seeing the people, I was so happy, and I think this is the way to go. If we exercise a lot, we know what we eat, we try to avoid the risk factor that we can avoid, then our disease, first of all, is going to be very less. And doing such type of conferences, this is a way. Every place, like when I was in Darbhanga at that time, there was no electricity. We used to study with lanterns. Yeah, or electric tubes with battery connected. But now I think things have changed a lot.
Yeah.
Even in Patna, things have changed. When I was coming from the airport to the hotel, I noticed that many changes have come forward. For example, your new airport, as soon as you reach here, is brand new. It is of an international standard. It's very clean everywhere. And I hope people maintain it clean, because cleanliness is the first step towards progress, towards responsibility, that we try not to litter the place where we live. And if we have that discipline in ourselves, so be it in the field of medicine or our routine day-to-day life, I think things are going to run better and faster. And having so many departments of cardiology and so many interventional cardiologists around now, there is no doubt that the future of cardiology in places like Bihar, or any, for that matter, any state of India, is very bright. We just have to keep on toiling, we just have to keep on working and improving.
Sir, I hear you have been running 24/7 STEMI program at your place. Whenever
In Mauritius.
in Mauritius. Yeah. So, you think at this point of time it is possible, or in what way we should work towards achieving that in here in Bihar?
So this is a topic of my lecture that I'm going to present in another half an hour.
Okay, then we'll hear.
So you can listen to it, but I can tell you, I was a junior most interventional cardiologist when I took charge of my unit. I had so many seniors who, for some reason or other, they didn't want to do primary PCI because we were scared. Maybe because we always thought that it was thrombus burden, and if we're going to put a stent in that, that may clog, that may clot, and that can block the artery. But my way of thinking was, and all the guidelines say, the primary PCI is the only way that you can save the life of patient with minimum complication.
Yes.
And if an artery is blocked in 10 cases, you can't block it more than 100%, and it is already blocked 100%. So if you're going to put a stent in that, even if that artery blocks, but it's not going to block than whatever it was previously, you see. So putting metal in a place where there is clot, I think, and studies have shown that there is no risk that we are going to block the artery any further. So you are going to only do good to that patient. And once you start doing primary PCI, because I took that courage, I took that responsibility on my shoulders, though I was not an experienced interventionist, I just used to do PCI, but not primary PCI. Before starting my first case of primary PCI on a routine basis in a government hospital, on a free basis, because in our country, government hospitals are free, it was thought of unthinkable that, that somebody who is so junior, without any experience, will even dare of thinking of doing primary
This
PCI.
you are talking in
Mauritius.
Which year, sir?
In Mauritius in 2020.
2020.
It started because in 2020, 1st September 2020, I became the head of my department. And right on the first day, I got my first patient of 40 years old. And that was the time when either I had to do it or I was still thrombolized the old way. So I took that courage, and that was the first primary PCI I was doing in my second primary PCI I was doing in my life, because I did one in private sector, and that was successful. And when it was successful, even the team saw that it is something that can be done. Till now, the patient is alive without any complication, and this is where it all started. I went to the ministry, I explained to the minister, we had to convince all the staff, the nursing staff, the doctors, because you have to really prepare the team, and somebody had to take the responsibility. So I was the one who took the responsibility. I started it, and we are 5 years after. Only in my center, we have done around 650 cases with very less and little complications, you can say, and most of our cases have been very successful. And it is something that can be done in minutes, 5 minutes, 10 minutes, 15 minutes, 20 minutes at the most. And you can see your patients improving instantaneously. Immediately, your ST is going down, chest pain is vanishing almost. And what is most important is, in the long term, the patient is only on 2 medicines. Instead of, if you thrombolize the patient and that artery is not open, patient may go in failure, he will end up with 8, 9, 10 medicines. Anti-failure, anti-ischemic, and then put a stent. And then when somebody is coming with an ACS, and we thrombolize the patient, anyway, you have to do an angiography afterwards.
Yeah.
Even if you put the patient on waiting list, you are doing it after 2 or 3 months. So you are doubling your work. First thrombolizing, and then second, you are going to do an angiography, then you're going to put a stent if the patient is still alive. You see, so you're wasting your time, pushing the patient to go into failure, using more medications, meaning more side effects to the patient. And if the patient goes in heart failure, that means his whole life is ruined, okay? In terms of his personal, his family, his professional life. And then who loses? The patient, the family, the community, the place where he works, the country, and everybody suffers, okay? And then the government has to fund these patients to give medicine, and then that's an additional cost. This is a vicious circle.
So,
and when you do primary PCI and the patient goes home, after 6 months you do an echocardiography, the LV is normal as yours and mine. The patient is only on 2 medication, 1 statin and 1 anti-aggregatory agent, and he lives a normal life like anybody. And everybody comes out. It is a profitable business house.
Yeah.
Like, for the patient, for the family, for the community, for his site of work, and for the country. So this is the impact of primary PCI that we can say, and it should be encouraged
And
to everybody and to every intervention center where we have a cancer.
so at the end, sir, what are the scope of improvements? I think there must be many, but according to you, in carrying out this kind of conference, which we are carrying out for the first time.
You need to have a leader, and if that leader is willing to give all the juniors, first of all, to train them and give all the juniors chances to perform primary PCI, they should go forward. And anybody can do it. It is easier to do a primary PCI than doing a calcified lesion with rotablation and doing stable lesions.
Thank you
Excuse
so
me
much.
again.
I was asking, do you have any suggestion regarding the scope of improvement in this conference? About our conference,
I think we are doing the conference for the first time.
first time.
Everything that you do first time, you are a bit scared, you are a bit worried whether it is going to be successful or not. But I can tell you now itself, it is a very successful conference even now. And any effort that you do towards improvement is always going to help. Like, Patna was not like this before,
Yeah.
but with those small changes, see where we are now.
Yeah.
We never used to do primary PCI in Mauritius. Now it's a routine practice. Everything needs to have a start. And this is a very good start, backed up with so many faculties and so many participants, national and international. I believe there is a big scope, and we should continue these types of conferences so that we can transmit to our juniors whatever we have learned. And one day when we are going to be patients of MI or heart failure, we are going to be treated better.
God forbid, sir, that happens to us.
That will happen to everybody,
Thank you so much, sir, for your time.
You're most welcome.